Hello, thank you very much.
Hello, Dr. Carlos. Yeah,
Hello, how are you? Nice to be here.
same here. Very good evening. I know it's already really late for you in Mexico, but yeah, thanks a lot for joining for this particular event. So I would just like to give a quick introduction about Dr. Carlos Zumarraga. He's from Mexico, and he's a medical doctor and founder of at Clínica Keto, a clinic and research center located in Mérida, Yucatán, Mexico. They offer a comprehensive clinical care approach for patients suffering from metabolic diseases derived from the excessive consumption of carbohydrates, which they call as the carbohydrate toxicity syndrome. The model of care integrates medicine, keto nutrition, and addiction therapy for allowing the individual patient to reach serenity and long-term remission of complex chronic diseases like IBS, intestinal permeability, obesity, fatty liver diseases, PCOS or infertility, and type 2 diabetes. And we are looking forward to learning a lot from you, Dr. Carlos, over the next 30 minutes. So let's jump onto this session, right? I mean, and we would really be happy to know your story, your own story about you embracing a low carb or ketogenic lifestyle. So please tell us about yourself. Maybe your journey in the US, what you basically learned over there, and then what exactly triggered you getting into ketogenic or low carb kind of a journey, lifestyle journey.
Yes, thank you very much. So, yes, I started this work some years ago. The basic premise is that I did a little bit of research in obesity, and at the beginning I started doing research in metabolic syndrome and obesity, and I started to do the low carbohydrate diet. And when I saw that I have good results with these diseases, I started to extend the research to other areas. And I started studying the low carbohydrate therapy and the ketogenic low carbohydrate therapy. And I tried to educate myself, and I visited the Duke Keto Medicine Clinic in North Carolina, in USA. And I learned from the Keto Medicine Clinic there in Duke. And I'm also been studying with Professor Tim Noakes from South Africa with Nutrition Network.
Great. Yeah.
And yeah, so we've been doing the academic work and also the clinical work in order to bring the therapy to the patients here in Mexico.
Amazing. Yeah. So, and how long you have been, let's say, on this ketogenic or let's say low carb kind of a lifestyle?
Yeah, we started in 2016 to see the first patients, and we have been doing the therapy and the research since then.
Okay.
And so today, my clinic is specifically focused in providing the keto medicine therapy for metabolic disease here in Mexico.
Yeah, that's wonderful. Almost 7 to 8 years into this is quite rewarding kind of an experience, and we would definitely like to know more about your patients and their success stories and things like that. So, but before that, I think how let's say as a clinical practitioner, how low carb happened? I mean, what was that moment when you thought about like getting into this and basically starting a keto clinic in Mexico? I mean, what exactly the kind of processes that you went through? Any particular incidences or events that you came across, and that's what made you more, let's say, going deeper into this and embracing this as a career in ketogenic diets? I mean, as we discussed, I mean, you're combining number of different therapies, and ketogenic is one of those. Addiction therapy is another, right? So what exactly is I mean, the trigger factor over here?
Yeah, I was doing in the past research in diabetes, and the focus on diabetes is that is a problem with the pancreas. Even the traditional therapy, they don't consider too much the insulin resistance aspect and the hyperinsulinemia aspect of type 2 diabetes.
Yeah.
And usually the medical establishment think that the type 2 diabetes is a problem with pancreatic failure. So the pancreas is not able to produce insulin in order to fix type 2 diabetes. But in reality, the problem is the periphery and the liver, the insulin resistance.
Mm-hmm.
So in this model, I was applying biologics in order to stimulate the pancreas to produce more insulin. Kind of, like the standard of care today, that when the patient is not getting better with medications, with oral medications, they try to apply exogenous insulin. But my idea was to focus on the regeneration of the pancreas.
Yeah.
So when I study more in depth the type 2 diabetes, I thought that maybe the best way to treat the disease was to stop, giving carbohydrates to the patient, because the problem is not that the patient is having a problem with the pancreas, but the patient is having too much insulin and insulin resistance.
Very true.
In a way, the most important thing for this problem, this specific problem with diabetes, is that you don't want to manage the problem. You don't want to manage the carbohydrate load that you give to the patient. What you want to do is you want to avoid the problem. You want to heal the patient. And in order to do that, what you have to do is to stop giving the carbohydrates.
Yes.
And this concept is very important, because you have to think what are the consequences of stopping giving carbohydrates to the patients. Because if the solution for a type 2 diabetic is to stop eating carbohydrates, and you do it, what will be the consequences of doing this? And the important thing is that the carbohydrate is a non-essential nutrient. So we can stop giving carbohydrates to the patients that are they don't tolerate the carbohydrate loads. And we can keep the system healthy with the other nutrients that are essential, like protein, fat, and vitamins, minerals, and so the essential nutrients are there in a ketogenic diet. So when we think like this, and we evolve our thinking, we understand in a deeper level the type 2 diabetes, then you can find a solution for this problem. And this problem is really a big problem in the world. The great majority of adults in Mexico suffer from obesity, metabolic syndrome, diabetes, all the diseases derive from insulin resistance, like neurodegenerative diseases like Alzheimer's disease. So in a way, when you understand these concepts, you can help the patients to heal and to improve the quality of life and the health of the society and the health of the families and the health of the individuals. So it's in a way, it's very inspiring to be doing this work.
True. And very, very nicely put, Dr. Carlos, that we are not supposed to be managing the disease. We have to be healing the disease. We need to be working towards making sure that we are either in remission or we have reversed that particular condition. So tell us more about the approach that you use, let's say, for treating your patients at your clinic. Any particular, let's say, method, or let's say combination of methods that you use, any validations that you do while a person or a patient comes to your clinic? What's the process looks like?
Yeah, so the process is like a medical interview. So the first thing that we do is we review the medical history of the patient. We review the laboratories, the imaging they may have. We review medications that are very important, supplements, if the patients are taking supplements, if the patient have allergies. So we do all the clinical history that is relevant to the clinical case. We establish a diagnosis. We also, it's very important to know what type of patient are you managing when you first encounter the patient. If you are treating a patient that is having hyperinsulinemia, type 2 diabetes, that has pancreatic reserve, or you are having a patient that is having an autoimmune condition that maybe you're having a LADA that is, or a type 1 diabetic that is having a destruction of the beta cells of the pancreas, and you are having a decrease in the population of cells, and this will create a lack of insulin. And this concept is very important to understand in the clinic because it has implications for the safety of the therapy for the patient. So this is more or less the first visit that we do. And at the same time, we check the patient in the weight, the height, we measure the waist circumference, we do a physical examination, and then we start teaching the therapeutic carbohydrate restriction. And we have a model of that is from is like an academic model that is in research, very similar to the one that I learned at Duke University, that is a program based on 20 grams of total carbohydrates a day to start the therapy. And we teach this, that is based on real food. We don't use a lot of oils or supplements or products or keto products or nothing like that. We have to be able to standardize the therapy to make sure that the patient understands the concept of having a baseline for the carbohydrate intake. So from there you have a reference where you will work. And this is important that you do it with real food. So we focus on meat, basically, on like pork and lamb and beef and chicken and seafood and eggs. So we start with this protein with fat as the center of the therapy. And then we add a little bit of leafy greens, a little bit of vegetables that is measured in a way that is no more than 20 grams of carbohydrates. And we also give a little bit of complements like a little bit of olives and avocados and a little bit of mayonnaise, a little bit of lard that is used for cooking. And you know, in this way we do the standardization of the diet. And then we fix the medications for the patients in order to start the therapy from day one. And then we follow with the patients because the patients will start healing and improving and removing the visceral fat and decreasing the insulin and improving the insulin sensitivity. And this will need more medication de-prescription or de-prescribing. And so this is what we follow. We make sure that the patient is not in any medication that is dangerous for creating hypoglycemia. And we make sure to follow for blood pressure as well. We teach the patients how to monitor the blood pressure at home, and we give some I give some margins of reference for the blood pressure. So if the pressure starts coming down because the patient is having the improvement in the water retention and the vasculature, because we can have improvement in vasodilation, and when we increase the vasodilation, we decrease the volume, we decrease the blood pressure. So this is something that is good for the patient that has high blood pressure, and we can start decreasing also the medications for these patients. And this is very satisfying to be able to heal the patient and to be able to return the patient to autonomy and to be autonomous and to be self-reliant and to recover the independence that makes the patient feel
A
feel
lot
well,
healthier.
feel
And
independent. Yes. So
wonderful, wonderful. And then this was so intense last few minutes, Dr. Carlos. I think can trigger probably another whole session of our discussion. So no, but I definitely would like to touch upon a few things, and this is really very helpful for our viewers. So one thing the takeaway from your practice is like 20 grams of carbohydrate restriction is something you mentioned, because carbohydrate toxicity is something that you definitely look at. So that's one thing. You also mentioned about patient care in terms of educating them, and then basically making them understand why we are doing it. So that's another very unique aspect that I'm seeing, which is actually leading to a success. And the last thing you mentioned about, if not carbohydrates, what is to be consumed is a lot of fat. So fat is at the center of this particular treatment. Now the question that comes to you, not my mind but viewers mind, is how your blood markers, I mean, you touched upon that, but can you walk us through, like, I mean, after, let's say, switching to high fat kind of diets, low carb or ketogenic diets, how the blood, how the reflection is on the blood markers, right? I mean, for most of these patients, and anything that you would like to talk about that?
yes,
Yeah.
of course, yes. So usually the patients come and we do a baseline level of laboratories. We check blood chemistries, we check blood cell counts, we check urine, the urine of the patients, the urine analysis.
Yeah.
So what we see usually is that we have patients that have metabolic disease. So usually we have patients that either they have diabetes, full-blown diabetes, or they will have, for example, metabolic syndrome or obesity, metabolic syndrome, and then diabetes. So it's like a spectrum of disease. What we see is that they come with high blood sugar. They come with waist circumference that is
Yes.
large. We see patients with high blood pressure. We see patients with hypertriglyceridemia,
Yep.
that is, the triglycerides are elevated, and we see patients with low HDL.
Mhm.
So this is the first time that I check for the labs is the way that I focus on diagnosing the metabolic health, how metabolically healthy the patient is. But usually we have patients that are more sick, like, for example, we can see the patients that have these metabolic syndrome markers, and they also have, for example, liver enzymes that are elevated, like ALT, AST, and GGT, and these are markers of hepatitis, non-alcoholic hepatitis or NASH, and usually these patients also have in the imaging, they have in the ultrasound or in a scan, you can see that the patients have fatty liver disease. And so you have the fatty liver disease in the imaging, you have the liver enzymes elevated, you have NASH, you have the metabolic syndrome. Sometimes the patients have everything. So you can also see, for example, in the urine that the patients have glucose, so they have glucosuria, and this is one of the problems with dehydration, and one of the having the triad in the clinic for the diabetics is that they are thirsty, they are hungry, and they are urinating all the time because they are having this osmotic aspect of the glucose in the urine, because they have surpassed the tolerance of the kidney, and then the kidney start sending the glucose to the urine, and this causes is a protection in a way, but in another way is a problem. Sometimes we see that patients that are taking, for example, Hardians, that they have glucosuria that is massive, like 1,000 units or 1,000 molecules. Sometimes these patients have a lot of problems with urine. They have urine infections that are chronic, that are repetitive, and we remove the flossins from the therapy of the patients, and we follow with the laboratories, and in 2 or 3 weeks all of these markers will improve dramatically. We also follow markers of inflammation like C-reactive protein. We follow, for example, in special patients, we follow testosterone, for example, for patients with polycystic ovarian syndrome. We also check for vitamin D levels, that is very common in Mexico, that we have low levels of vitamin D. So we check also what other labs do we check. So the urine, something special. Sometimes we do. We also follow for sure. We follow insulin. You know, the fasting insulin, and we check hemoglobin A1C to see how bad the patient is in long term, in 90 days. And then sometimes we have to check C-peptide, that this can be elevated in some patients, that can be decreased in other patients. And this marker is very important for our research in our clinic, as well as the fasting insulin and all the others as well, because it's like this is a disease that is a syndrome that is created in the spectrum of expression, clinical expression of disease, but in reality you are having the excessive consumption of carbohydrates above the personal carbohydrate threshold, and then you are generating the disease that can be fixed and can be reversed with a low carbohydrate diet, ketogenic diet.
Amazing, amazing. So it is basically you're treating the entire system and not just, let's say, one particular parameter, you're trying to fix that. So that's an amazing, well-rounded approach. Now, the next aspect that comes to my mind is what are the how many times the patients basically comes back to the clinic because he or she is not able to sustain, right? So how's the sustainability factor comes into play here? Do you want to reflect on that?
Yes. The sustainability of the ketogenic diet is it's variable, but in a way I can tell that maybe we have like 60% of the patients that can maintain the therapy long term. But the most important thing for sustainability is that the patient has a motive. So it has a reason to do the program. And is convinced to do the program. So the patients that are convinced, that have a reason for doing the ketogenic diet, they will stay in the program. But we have to help the patients to remain in the program, because sustainability is associated, is related with cravings and the addiction aspect of the carbohydrate. So we have to fix all the pathways that are related to reaching serenity, or food serenity, or sobriety. And this is a biological and a psychological problem. So it's not only something that is a behavioral problem, but it's a biological problem as well. So we have to fix the glucose variability. That's one of the first things that we have to do, to fix the glucose variability, because when the glucose is variable and you have peaks and dips of glucose, the patient is in a stress state. So it's difficult to maintain a program if you're having volatility in glucose. So the ketogenic diet will stabilize the variability of glucose, and this will help the brain to get access to energy in the forms of ketones, but also to not have the variability of glucose. So these are two important aspects of the therapy: stability of glucose and also the access to energy, to the ketogenic, to the ketones from the brain. The brain really like to it's eager to use ketones to work. It's as well as the heart. So when you give the opportunity to the brain to switch to the ketogenic diet, the brain gets better in many ways. So this is the first step. The second level, it's also in the brain, that is in the limbic system. So this is important that in our program, we focus on real food, and we try to avoid everything that is addictive or is processed food, like keto products and all of this industry that is around the ketogenic diet, that is really not really ketogenic, because in order to be in a ketogenic state, you have to be below your personal carb threshold. So you cannot promise that this product will be ketogenic for this patient, because this patient can have a very low threshold. in a way, the products are really not objective in a way. They are not
True.
fulfilling the promise. And also, these products keep the dopamine system hyperactive. And the patients start, they continue to have cravings, and having cravings is one of the problems to sustainability. So if when we give a well-formulated real food ketogenic diet, we avoid all of this processed food, and we get the patient into a new set point for dopamine, where we don't have the peaks of dopamine and the crashes of dopamine, and we help with the cravings. This also helps to the sustainability. And the third aspect is that once the patient is well it's in a good state in the biology with the glucose and the ketones and the dopamine, then you have to work with the patient with the motives, and you have to work with the patient with intention, and the patient start having a higher level of cognition, because they work from the cortex, that is the higher level of ability or capability of the human, and then you can direct the program. But this is very fragile. It's a system that is very fragile. So you have to keep the patient at least 1 year in a program like this in order to create a new habit, and to heal the brain, and to establish a new lifestyle that is therapeutic and is beneficial for putting the metabolic disease of the patient in remission.
That's a very very valid point about maybe taking this particular process for at least, let's say, an year, so that that basically becomes an habit. It becomes a cognitively accepted kind of a behavior. So wonderful points. We have 3 minutes, 2 minutes left into this conversation. Just 1 or 2 quick questions. One is on the IBS and the other one is on the cancer patients. I think both you have been treating. Do you want to suggest anything how, let's say, low carb or ketogenic diet can help in IBS or cancer?
Sure. So in IBS, the problem is that usually the IBS is considered a psychosomatic disease. So that is triggered by, for example, stress. Usually the patients are bloated, they have colic, they have pain, they have distension of the abdomen because they have a lot of gas. So in reality, what we see with the ketogenic diet is that when we decrease the amount of carbohydrates, and the fermentation in the gut decreases, and then the gas decreases, and the inflammation decreases. Usually with a ketogenic diet, as a 20-gram ketogenic diet, this will work almost always for the IBS, and also for the the gastrointestinal tract, from the gastritis to the colitis to the gastroesophageal reflux disease. All of these diseases get better with the ketogenic diet.
So Dr. Carlos, sorry. I would like to pause for maybe a second, because we are approaching the top of the hour. Sorry about that. I wish we would have continued for longer, but I'm sure that we will definitely be having another session with you. There is lot to learn from your experience that you're having in treating patients, right? I mean, in Mexico. So Shashi, would you like to have, let's say, the final few words? Can Shashi be here? Can we bring him in the main room spotlight? Yeah, thank you.
Thank you, Yogesh. Dr. Carlos, I wanted to thank you personally for appearing in this historic event of India. And Dr. Carlos is my colleague from Nutrition Network, and I'm so happy to have him represent Mexico in this low carb from across the globe. Thank you for sharing. You have a lot to share, and we will have a little more extended program, maybe in D-Life podcast, and we'll be so happy to have little more knowledge from you. Thank you, Carlos. And
thank you, Dr. Carlos, and thanks for your time late in the evening. Appreciate it.
Thank you. Thank you very much to everyone. Thank you, Shashi. Thank you, Yogesh. I appreciate this opportunity, and I'm very happy to be here and to participate, and it's an honor to be here. So we'll keep in touch, and
Yeah.
we have a lot to discuss in the future. Thank you.